Dr. Marenko, Lena?
Yeah, I'm sharing my screen now. Can you see my screen?
Not yet. Okay, now.
All right, sounds good. Well, good morning. My name is Leah Marenko. I'm a postdoc here with Dr. Chechana, and today I'm going to be presenting a case of a sinonasal anterior skull-based tumor that was operated on by Dr. Chechana, Almeida, and Dr. Olomu. First off, I just want to thank everybody that's part of this multidisciplinary team that took care of the patient. And I want to give special thanks to Diana, who was the one who edited the operative video. She's a neurosurgery PGY4 from El Cruce Hospital in Argentina. And she is currently doing a fellowship at Mayo Clinic right now with Dr. Almeida. So this is a 67-year-old woman who initially came for evaluation and management of a skull-based tumor by neurosurgery. Her symptoms started in fall of 2020, where she developed nasal congestion and increased runny nose and intermittent bleeding. And they worsened in spring of 2022 with increased right-sided nasal congestion. But in April of the same year, she had an episode when she was driving with dizziness, blurred vision, and palpitations. Thinking she was having a stroke, she went to the ER where they performed a CT, and they found a lesion, an intranasal lesion on the right side, which was initially read as a polyp. On September of 2022, she contracted COVID, and her symptoms worsened with increased difficulty breathing out of that right nostril. And for this reason, she was referred to ENT, and she underwent a biopsy of the lesion, which was consistent with anesthesia neuroblastoma. In review of systems, as we said before, the patient had nasal congestion and runny nose, atrial fibrillation, past medical history, rheumatoid arthritis. She's on rivaroxaban and methotrexate. Allergies are non-contributory. Family history was non-contributory. She doesn't smoke. She occasionally consumes alcohol, and she works as a minister and is married. On a physical exam, the patient, it was within normal limits, except on a speculum examination of the nose, showed a mass on the right nasal cavity. So this is the axial CT, the preoperative axial CT, where you can see on the right nasal cavity, a mass that is extending from the posterior margin of the nasal vestibule to the posterior nasal cavity. And we have some signs of bone erosion and aggressiveness here in the coronal CT, where we can see that this mass has or eroded the perpendicular plate of the ethmoid bone. It also has gone through the right cribiform plate, and it is abutting the lamina papyrigia and it's thinning out the lamina papyrigia. I don't know if Dr. Agarwal, you want to comment more on this?
Yeah, just a quick comment that these tumors can be very slow growing. So, of course, this is the follow-up CT, but on the initial CT, it just looked like a polyp. And at that point of time, there is no obvious bony destruction. It's just smooth bony remodeling. So at an early stage, it's very difficult to demarcate these from any other nasal tumor, like an inflammatory polyp or sinonasal tumors.
So what I'll add to this is, if you're looking at a nasal polyp in a nose, how I differentiate between something that may be malignant versus inflammatory is, if it's unilateral, that makes it more likely to be something more malignant. And the second thing is, if there is no surrounding inflammation of any of the other sinuses, especially of the ethmoids, it means this is not an atopic patient. It's not a patient with a lot of allergies or inflammatory sinus disease. So if you see a polyp with no surrounding inflammation, that's much more likely to be something malignant. If there was inflammation in the ethmoid, for example, in the macular sinus, that's much more likely to be an inflammatory polyp because all the mucosa is responding.
Thank you. We're gonna go forward. So to evaluate the extent of intracranial extension, preoperative MRI was performed. And as we can see here, there is on, well, first of all, we just have to say that this lesion is not really typical of what we would expect an esthesia neuroblastoma to look like. These lesions are usually multilobulated, highly invasive into intracranially and cystic. And then here, as you can see on the axial T1 postcad, we have this contrast enhancing mass that extends from the posterior vestibule to the anterior sphenoid sinus. And then here on the coronal T1 postcad, we can see that the mass is displacing the septum towards the left, and it's abutting the lamina papyracea without any intraorbital invasion. And on the sagittal T2, we see this hyperintense mass that goes from the nasal floor upwards and through the cribiform and arose through the cribiform plate. I don't know if Dr. Agarwal, do you want to add anything else to this?
Yeah, Lina, as you said, this is not a classic textbook picture of a olfactory neuroblastoma. The classic described findings include a intracranial component with intratumoral cyst, but if it is limited to the nasal cavity, then it's very difficult to demarcate other malignant tumors like sinonasal carcinomas, adenocarcinoma from esthesia neuroblastoma. So at this point, the differentials should have been wide, including sinonasal tumors, cancers, and esthesia neuroblastoma.
So as Dr. Agarwal was mentioning, we know this is a biopsy confirmed esthesia neuroblastoma, but other differential diagnoses include a nasal adenocarcinoma, sinonasal undifferentiated carcinoma, and last, an olfactory groove meningioma. Treatment options include resection, radiotherapy, and oncological management with chemotherapy.
So what I'd like to add is, in a mass like this, that's obviously going to be visible in the nose, the next step is really office biopsy. It's very easy for ENT to take a little piece of it in the office and completely answer the question of what it is, which may change management significantly. So that's what we did for her. She came to the clinic and we did a biopsy in the clinic and sent her to pathology.
Okay. So because like Dr. Olumu said, this is a biopsy proven esthesia neuroblastoma. And we know that extensive resection improves prognosis. The plan was for the patient to undergo an endoscopic endonasal trasncribiform approach with a fascia lata graft. The risk and complications include CSF leak, intracranial hemorrhage, epistaxis, infection, hydrocephalus, and pneumocephalus.
I would just say, like in your previous slide, just to define the resection that really is a watershed in terms of determining prognosis here is really complete resection with negative margins, right? So this is different from the other tumors that we deal with. So this is a a sinonasal malignancy, and that's really the goal of the surgery. And Dr. Olomu can further describe, but that's one of the ways that we look at about how to define the approach that we're going to be selecting. So as you described pretty well, we didn't have intraorbital invasion with distortion of the periorbit, and we did not have a major intracranial component, and we didn't have a perineural dissemination through all the nerves, but the olfactory nerve, and all of that helps to determine. Also, the frontal sinus was not affected, and so it all points to a nice case for endoscopic endonasal approach. But some of those, not necessarily esthesia neuroblastomas, but malignancies, when they extend from the nasal cavity through the orbit, for example, or extend more laterally, it may be very well be the case when one has to combine or even go purely with a transfacial approach, or combined with an endoscopic endonasal approach. And those are important points, different from, for example, meningiomas that we treat in this area.
The only other thing I'd add is when you talk about risk with a patient, you have to mention anosmia. This is almost in most patients going to lead to anosmia. Sometimes you can preserve one olfactory bulb, but that is not the goal. The goal is complete surgical oncologic resection.
Okay.
The other thing to mention in your surgical resection is that this one is not as large, but these tumors can be very bloody, and at times, especially with larger tumors, preoperative embolization can be helpful for decreasing your surgery time and making it easier to see and get around things.
Yeah, I would like to hear Dr. Lomo experience. Like for the esthesioneuroblastomas, at least my experience is that they often do not present such a challenge in terms of bleeding, differently so from the juvenile nasolateral fibromas, which they're definitely benefit of preoperative embolization. But
Yeah, the GNAs 100% will get preoperative embolization. With the aesthesios, they used to be very bloody, but the techniques have improved that significantly, such as early management of the anterior ethmoidal artery, early management of the sternocleidomastoid artery vascular distribution. And so I don't embolize these anymore. I only embolize GNAs now because those will be very bloody otherwise.
So just continuing on, the patient was positioned supine, reverse Trendelenburg. There wasn't any head fixation. The head was placed on a donut. The arms were kept along the body. The right leg was prepped for harvesting the fascia lata. Lumbar drain was inserted prior to the surgery, and both neurosurgery and ENT worked together on the right side of the patient for the surgery. And this is the approach. And I don't know, Dr. Lomo, if you want to describe the intranasal portion of the surgery.
So that's the tumor itself. We are looking in the right nostril. We're medial to the middle turbinate trasncribiform. So I started by removing the middle turbinates there, just to give myself more space. Then I perform a maxillary antrostomy, again to improve visualization, remove all the surrounding ethmoid cells and open the sphenoid sinus as well, which sort of gives us the view of the entire skull base. So the other thing this allows us to do is to see whether or not we can preserve the nasoseptal flap for reconstruction. So you're going to want a careful margin on the nasoseptal flap superiorly to make sure it's not involved in tumor. And that's what I'm going to get to next. So that's the sphenoid sinus that we're looking into. So now I am defining the nasoseptal flap with the Bovie. I'm staying definitely more than 10 millimeters away from the tumor. And that is my margin on the nasoseptal flap to ensure that it is not involved with tumor. And we'll send that for frozen. Next, I'm going to elevate, and that's further margin. So I take a margin of every bit of that. So next, I'm going to remove all the, I'm going to the contralateral side, doing an exposure there as well. Again, we want to have the entire skull base available to us. We don't want to be limited by the ethmoid sinuses. So I'm going to complete the maxillary antrostomy there. Then now I'm going to do a total ethmoidectomy on this left side. That's a sphenoid sinus, expanding that. And then I'm now completing the total ethmoidectomy and exposing the skull base on the left side. So now that my margins have come back clear, I'm now going to complete the elevation of my nasoseptal flap. It has to be a very large flap because we are planning to essentially cover the skull base from orbits to orbits. So I involve most of the mucosa of the floor of the nose in this flap. So there, after the flap is elevated, now going to start going after the tumor itself, at least defining its margins. So they're elevating mucosa. Again, we've already checked the margins. So the goal is to see exactly where the tumor is attached to the skull base on the cribriform. So there's a view of the sphenoid sinus. You can see a full exposure of the skull base bilaterally. From here, we can definitely have good control of our margins. Not sure if this jumped a little bit.
Yeah, it is a
So
bit
now,
jumpy. I agree.
so now we are neurosurgery has come in, and we're now going after
Sure.
the intracranial portion of the tumor.
Absolutely. So basically, you see now that after Dr. Lomo finished the the nasal part of the procedure, then we focus our attention in the skull base in the anterior fossa floor. So if you stop the video for a second, Lena. Okay, it's good because it's gonna allow time for the video to load a bit, I think. You see that the exposure that was done, like with the completed myodectomies and the middle turbinectomies on both sides, basically exposes the opportunity to identify the middle of the orbit or lamina papyracea on the right side here. And then here you got on the left side, you're gonna have this middle of the orbit here as well. And here you got in the midline, you got this area here, which will be the cribriform plate. And then laterally on both sides, you got on the right, the fovea ethmoidalis on the right, and you got the fovea on the left. And then we're gonna be drilling this area with careful attention to understand the relationship with two vessels, two on each side, by the way. The anterior ethmoidal artery that we're going to be seeing in a second, and the posterior ethmoidal artery. And that's the same thing on the other side. So as you see, this is a diamond bore, a diamond drill. And then we need to be able to drill in between those spaces, thin out the bone, elevate the thin piece of bone that is covering the channels or the canals of those arteries, and then we can coagulate and sacrifice those arteries. That's most important part of this. So let's play the video for a second. And then you see that that's the first one. So that's the right posterior ethmoidal artery. It has a perpendicular course from the orbit towards the midline. And now you have the left posterior ethmoidal artery. Thanks, Dr. Olomo. He has a case, but thank you so much for joining us today, Noma. So you see drilling, exposure, coagulation, and sacrifice of the posterior ethmoidals. And now as we go forward towards the frontal sinus, the anatomical reference becomes the anterior ethmoidal. So those two vessels go as well. After that's done, you see that in this case, there was an extension of the tumor extending more so towards the right side. And that's why we're doing this asymmetrical extension towards the orbit on the right side. The drill is then completed in a 360 fashion, exposing the dura mater, as you see here. You see that we're basically dissecting some of the thin bone left. And then in the most anterior part, you see that still there is some bone, and you see this big bone. Can you pause the video? Maybe go a bit backwards. Yeah, perfect. And you see that we have this bone here that we're basically right now dissecting the dura away from it. So separating from midline, laterally, both same maneuver on both sides. And that's going to be the end or most cranial part of the perpendicular plate of the ethmoid bone extending up towards crista galli. So the crista galli, you have to notice that I still kept like some bone up here, and that was just to allow me to dissect that a bit more, so it's not floating attached only to dura. And then we can drill a bit, thin it out, and then we can remove the crista galli as less part of the bone work of the surgery. So you can go ahead and play. So you see, just thinning out the crista galli, just like what we would do, for example, with a clinoid. And then this bone can be mobilized. The crista galli can then be mobilized from, superior to inferior, or often from front to back. And this bony removal extends up to a point that we call foramen sacrum, that is located in the most anterior aspect, right behind the posterior wall of the frontal sinus. Once that's done, you see that we're opening the dura on the right side, which there is tumor extension. So you see tumor there. Can you stop the video? You would have to go back a bit. Perfect. So you see here that we have tumor here attached to the dura. No, I mean, I don't know if you could play and stop there where you were.
Yeah, sorry about that.
Okay, so he. Yeah, just stop. Okay, good. Yeah, no. Yeah, right there.
Yeah.
Okay, thank you. So basically here you have the tumor that is extending and attaching to the dura in the skull base of that right side. What you see here, some of the adhesions in this tumor, has this close relationship with the olfactory bulb and olfactory tract that you see here, the olfactory tract. And here you see the frontal basal artery on the right side and the posterior frontal gyri on the right side as well. So we're going to be dissecting that area, and then we're going to go ahead and with this, intracranial extension, at least in my opinion, it's a bit of a no-brainer that we should drop the entire dura and also get tissue margins from the left side to make sure we have negative margins. So go ahead, please. We do the same maneuver on the left side. So the method is exactly the same. So open the dura, and then you can, in this case, communicate to the top. Ligate, one important aspect here is that you have to ligate as close as possible to foramen sacrum. That will facilitate the transection of the fox. And here you see that we are transecting the interhemispheric of the fox. And this is an important maneuver. Also, you need to drop your hand in a 90-degree angle so you can not go all the way to the convex tip, but bring it down. And then as a last part of the procedure, you're expecting here the olfactory tract on the left side, isolating it away from the left frontal basal lobe and removing and sending that to pathology. All of those fragments, and can you stop the video, please, again? This is important. All of those fragments, they are sent to pathology, and we got, frozen sections and we got permanent sections. So we have, I don't even know how many numbers of frozen sent to pathology. So it's a very important work done together with pathology. I would need you to go back, Lena, so we can talk about the reconstruction, please. And then with that work, we can get basically the confirmation of negative margins, so we can get or expectation of surgery. And if we don't get negative margins, we need to continue pushing the surgery until we do so. So the reconstruction in this case, you see the initial part with a dura substitute placed there, followed by fascia lata, and then as a last piece of the reconstruction, vascularized nasoseptal flap that Dr. Olomo had harvested at the beginning of the case. And then it was just kept in place with fibrin glue and nasal pore, which is an absorbable, packing material. Thank you, Lena. Let's go ahead with the post-op for the sake of time.
So post-op, we're just gonna see that there was complete resection of the lesion. This is the pre-op, and to compare, this is the post-op. And all that we see are just post-surgical changes. I don't know if Dr. Agarwal wants to say anything else. And this is just to show the same thing, that there was complete resection of that lesion. All right. So post-operatively, the patient did well. She was in the ICU. She was febrile and hemodynamically stable. The neurological exam was baseline, the pain was well controlled, and she did not have any CSF leaks. On day 2, she had some serosanguinous oozing from her nostrils, but she was discharged on day 3 with doxycycline, Diamox, and oxycodone, with follow-up with ENT and neurosurgery in 2 weeks, and continued follow-up with neuro-oncology. When she was seen by neurosurgery at 2 weeks, she was doing well without any drainage. She was scheduled for follow-up in 6 months with an MRI of the face with and without contrast. And they referred her to neuro-oncology and radiation oncology. Radiation oncology started IMRT, IGRT late this January for the patient to receive 60 grays in total and 30 fractions. As of February 13, she has received 11 fractions. Neuro-oncology ordered a PET CT, which did not evidence any metastatic disease, and they referred her for management with oncology with Dr. Zhao, where they were discussing to start her on chemotherapy with cisplatin and etoposide, depending on the pathological analysis. If the tumor was low grade, then chemotherapy was decided not to be added. And this is just the PET showing that there weren't any metastatic lesions. So pathology, we can see that there's like a very monotonous cell population. Dr. Gentov submitted some audio, but I don't know if you can hear. I'm just going to say it's a very monotonous cell population with very little pleomorphism. And you can see the salt and pepper nucleus, which are chromatin dots within the nucleus, which is characteristic of neuroendocrine tumors. And this is consistent with the diagnosis of anesthesia neuroblastoma. And then as we go to higher power, we can see that there is mitotic activity, which is shown here. There's no necrosis, and the nuclei do not show a lot of nuclear pleomorphism. There's a monotonous population. So this is important for the Heim score for the pathological grading of this tumor. On staining, we can see that there's a pattern of tumor. There's a pattern of staining. The tumor was chromogranin positive, synaptophysin positive, and it had a subtentacular pattern of S100 staining. And this is consistent with neuroendocrine differentiation. And the final diagnosis is anesthesia neuroblastoma, Heim's grade 2 to 3. The Heim's grade is a pathological grading scale. 1 to 2 is low grade, 3 to 4 is high grade. So this was an intermediate between 2 to 3. And this study just shows which was performed at Mayo Clinic Rochester by Dr. Van Gompel and Dr. Link. And then here you can see the characteristics of that differentiates the 4 grades for neuroblastoma according to the Heim's grade. And because the tumor for this patient didn't have a lot of pleomorphism, didn't have any necrosis, but did have some mitosis, you can see that it falls within this intermediate grading between 2 to 3. And then on the right side, you can see that tumors which have a higher grade, meaning 3 and 4, have a worsened overall survival versus 1 to 2 which are low grade. And then here you can see with when you separate them out and you are more granular into 1, 2, 3, and 4, we can see that even though 3 and 4 are higher grade, the grade 3 behave more like grade 1 and 2 and has a better prognosis than grade 4. Okay, and that's everything.
Thank you, Lina. A very nice presentation, and I think definitely so important, pathology for us to be cognizant and to understand the management and the important classifications to be able to deal with. Kai, any comments you'd like to share?
Yeah, I guess just like everyone was saying, the main thing for these cases is you don't want to go small. You need to get negative margins and definite negative margins. If there's any ambiguity, you need to go wider, just because that's really where the outcomes are.
Yeah, I couldn't agree more. Fully agree. And what's up for next week, next Monday? Diogo, Andrea?
Yeah, so we're going to have the presentations that some of us have had at conferences. So we're going to have Gaetano and myself presenting the work we're going to be presenting at WNS, and then Carlos, the work is presenting at Skull Base, and then Andres, the work he presented at Southern. So join us next Monday, everyone. And thank you for joining us today.
Thank you. Bye-bye, everybody.